Welcome to the House Committee on Health, Human Services, and Elderly Affairs. As noticed, we have several Senate bills we're going to be looking at and hearing about today, but before we get to those, please join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you, everyone. The first bill to be considered today and to be heard is Senate Bill 18. The prime sponsor is Senator Rosenwald, but very ably filling in for Senator Rosenwald is Representative Lucy Weber from Walpole. Not often we see Representative Weber sitting over there. Usually she's sitting over here, but welcome, Representative Weber.
Thank you very much. For the record, my name is Lucy Weber. I represent Cheshire 5, and I am pleased to introduce Senate Bill 18, permitting the Commissioner of Health and Human Services to authorize additional beds for a pediatric intermediate care facility under certain circumstances. And what I would say is that this sounds very broad and very amorphous, but what I am told is there is only one facility in the state that this rule applies to. And if you look at paragraph 2 of the bill, these are exceptions for beds in a very specialized facility. This facility is Cedar Crest, it's in Keene, and the population that it serves is both developmentally disabled and very medically fragile. So it is a very specialized population. And there isn't anywhere else that knows how to properly both treat and educate these children. So several years ago, you will see language on lines 10 to 13 that authorizes 2 additional beds for the facility. And what you're going to see is in addition to that, on lines 14 through 20, is the authorization for the commissioner to come to the fiscal committee and ask for the authorization of further beds should they be needed. So there is no mandate of any sort, but there is a mechanism by which these beds could become available if they were needed in a relatively speedy manner rather than waiting for the whole cycle of legislation to come around again. So with that, I'd take questions, but I think that there are people sitting behind me who are much better able than I to answer them. So with that, I will take any that you have, but hope that you won't.
Any questions for Representative Weber? Representative Mazur.
Thank you, Mr. Chair. I think it's an easier question. You mentioned Cedar Crest and Keene is the only one. So would their staffing accommodate an increase of 2 patients?
I don't know the direct answer to that right now, but I assume that neither Cedar Crest nor the commissioner would be asking for extra beds unless they had the capacity. So, and I believe that the director is supposed to be here. So my hope is that you'll have a better answer than I can give.
Anyone else? Seeing no one else. Thank you, Representative Weber.
Thank you.
Also signed up to speak is Jay Haston from Cedar Crest. Based on Representative Weber's comment, you have all the answers, sir. So, no pressure.
I will do my best. Thank you, Mr. Chair, honorable members. Appreciate the opportunity to speak in the consideration for this bill. My name is Jay Haston. I'm the president and CEO of the Cedar Crest Center for Children with Disabilities. As you heard, we provide complex care and education to the state's most medically and developmentally fragile children. Our job each day is to handle incredibly challenging medical, developmental, and therapeutic needs so that these kids can be kids, so that they can play and learn and grow. As you're probably aware, we are an intermediate care facility, and we're the only one in the state that serves this population. Our age range as of today is from infancy through age 22. We're both a home and a school. And as you heard, we specialize in children with both medical and developmental needs that are very complex. To give you an idea of that medical complexity, of the 24 long-term admissions in our facility now, 9 use ventilators for all or part of the day to help them breathe. 100% of our residents have a G or a GJ tube through which they get the majority of their life-sustaining nutrition. And nearly half have a tracheotomy site, a hole in the airway, for supplementary breathing treatments and other breathing supports. You may know it is relatively rare to find a single ventilator in a skilled nursing facility in the state of New Hampshire. We have 9. At times, we've had 10 or more. We also provide special education instruction in an approved private school on our premises, and we provide quite a lot of respite care to give families and caregivers, when children live at home with family, a break. They can come and stay with us for a couple of days, up to 30 days at a time. Some additional context: last year we had 7 long-term admissions and over 62 different respite stays. That supported more than 20 families to maintain the ability of children to live at home with family. The average age at admission for us is just under 7. Quite a lot of our admissions are from the hospital in infancy, and then we do occasionally get older children who come to us when their family caregiving situation changes. The average length of stay, including folks that do not have a family situation to return to, as well as folks who will be with us for just a short period of time, our average length of stay, factoring in all of those stays, is just under 3 years. And that includes children who are followed by DCYF, children who are actively working to transition home, as well as children who don't have a home situation to transition to. Since the pandemic, the demand for our level of specialized care has cumulatively increased by more than a third. We receive more inquiries per month than we can currently support with our capacity. There is also some seasonal variation in demand. Each year, we tend to be full and have a waiting list during the warmer weather months, during the respiratory illness season. Given the respiratory challenges that many of the children face, we tend to have fewer referrals. Folks tend to remain in acute care settings longer. To address a question we heard a moment ago, our workforce, thankfully, is very strong, and we would love nothing more than to provide our specialized care and therapies to additional children and families in need. We have the staff, the specialists, and the bandwidth to meet it. What we don't always have is the permission to serve those children, given capacity limitations. We are the only pediatric post-acute environment throughout northern New England that provides this level of service, and our hospital partners and care teams, most often Dartmouth, but occasionally the Boston hospitals, would really like to discharge children to our setting. Whether it is Dartmouth or Franciscans, those settings don't have a full-time school that children go to each day. Those settings don't have the same range of activities, community engagements, field trips, the types of activities and engagement that children deserve as part of their learning and growing process. We do, and we would love to offer it. Getting those children out of the acute setting also frees up those beds for more acute cases, and ultimately saves the taxpayers money. It is quite a lot more expensive per bed day for a child meeting Cedar Crest's need profile to be inpatient at a specialized hospital as opposed to being with us. We are very grateful that our number of beds was temporarily expanded again last year. We utilized that capacity multiple times during the year, and we maintain an active list of respite and long stay inquiries. We are thankful to Senator Rosenwald and the co-sponsors for identifying a possibly more durable pathway to consider and respond to this need. by involving Health and Human Services as well as the fiscal committee. This is a very unique population whose needs are well met in our setting, and as the only facility providing the level of care that they need, we thank you for hearing this bill and urge its passage as introduced.
Thank you. Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. So, as you mentioned, there is the demand, and the demand is chronic. You also mentioned that you have the bandwidth, and you also mentioned that you're the only facility that provides these services. So, why cap it at 2? I understand there's a provision that you can go back for more by going back before the fiscal committee, but understanding that you're the only one and that you have the bandwidth, was there a reason that 2 additional beds was chosen, and that you have to involve the fiscal committee? I'm just trying to understand that.
Sure. I think, I don't want to speak for the senator, but I believe part of the consideration was to have additional consideration validating the need by someone like the Health and Human Services Commissioner, and then involving the fiscal committee to validate potential expense. Our facility can't easily accommodate much more than a couple additional beds without considering moving things around or possible expansion. So functionally, in the short term, two beds has met the need for what we have and what we're seeing on the wait list. Long term, may we need more? Perhaps. Yeah, does that answer your question?
Follow up?
Thank you. So functionally, given some of the logistical concerns that go beyond the 2-bed, if the bill were to be expanded to be more than that, would that give you more latitude to look and to plan, understanding that you had more latitude? And I don't understand the concerns of the fiscal committee. Maybe somebody from the department might be able to address that. But that aside, if you had the capacity, the legal capability to put in more beds, would that alter your planning for the future?
It would certainly ease some of our longer term planning in terms of what the 3, 5, 10-year plan looks like. Because we have such a small number of folks that we serve, we're very vulnerable to small sample size problems in assessing future need. I will say in the 3.5 years that I've been there and looking back over or 10 years of data, we have steadily increased in demand, particularly following the public health emergency. And so if there were the opportunity to consider additional capacity, I think it would be helpful for long-term planning. And I think our current census trend suggests that there is an increasing need, in part because of advances in medical technology and frankly, more children surviving and being able to leave the hospital than have in the past.
Thank you.
Other questions? Representative Lucas. Then
Just
Representative McKay.
a semantic question. The act is in regard to a pediatric intermediate care facility. And then down on line 15, it says something about an immediate care facility. Is that a typo, or are those 2 different facilities that?
That appears to be a typographical error.
Okay. So should it be intermediate on line 15 as well?
It should.
Okay.
All set. Representative McKay.
Thank you, Mr. Chairman. In your discussion, you mentioned that some of the children you see have developmental disorders. That means all kinds of things to many people. I don't know if you mean mental health issues, and because the stigma with the word mental health, sometimes people will use other words like developmental, but we're all developmental individuals. So I'm wondering if it means that you are seeing children with mental health difficulties.
Happy to expand on that. So the primary population that we serve has significant developmental disabilities, Clinically, you may sometimes see that referred to as mental retardation, although that is no longer commonly used. It's still a valid clinical diagnosis, but the terminology has shifted. And when you look at significant developmental disabilities, so often that's tied to a significantly lower than normal IQ, as well as impacts on an ability of a person to live independently. Generally, there are 4 standard deviations. So mild disability, moderate disability, severe, and profound. Generally speaking, the children that we serve are in the most severely and profoundly disabled categories. So primarily developmental, how they learn, how they interact with the world. While it often happens that there are mental health challenges that go along with that, mental health is not our primary focus in terms of service need. It is more the impacted mental capacity.
Follow up.
Follow up.
So that I understand, you did mean developmental intelligence
Correct.
and not mental health
Correct, sir.
issues. I'm a little bit disappointed because we're all looking for health care for children. But thank you for your work. Thank you.
Thank you.
Other questions? Yes, Representative DeLemus.
Thank you, Mr. Chairman, and thank you for taking my question. It's really simple. How many beds do you have? And I know you have categories of or levels of illness, I guess I should say, or dis-ease. Do you have those beds like 7 and 7 and 7, or how's that
Oh.
work?
Got it. So historically, we've had a license capacity of 26, and over the past few years, we've had acts that have increased that by 1, and last year by 2 beds. So currently, we have 28, although that is set to expire at the end of next fiscal year. We have both levels of developmental disability that we consider in terms of a service mix for the children that we're working with. There's also a level of medical acuity. And so we have a handful of rates that are tied to the medical acuity. So our rates of reimbursement, our sort of bed day rate is tied to a combination of factors, primarily around the medical acuity. So for example, our highest rate is for children who use a ventilator for the majority of the day, and their airways are not stable on that ventilator. So they're requiring interactions and treatments from a nurse multiple times per hour. And then all the way down through our lowest rate is for children who have a medical need that requires nursing intervention multiple times per 8-hour shift, but not the same kind of frequency per hour. So even our least complex children are still very medically complex.
Follow up.
Thank you, Mr. Chair. So the two additional beds just go where they're needed. Is that what I'm? Yeah.
Correct.
Okay, great. Thank you. And God bless you guys for doing that work.
Other questions? Representative Kesselring.
Thank you, Mr. Chair. So I have a question. You said that the 2 that was increased was the kind of the most that you could do. Does the facility currently have the ability to go beyond what you currently have?
Got it. In case of emergency, we have flexible spaces that we could engage for something like an emergency removal by DCYF. You know, sometimes these things are time sensitive, and Dartmouth Children's may not be able to accommodate more than a very short stay. So we do have some flexible spaces that could be turned to that purpose. One of the things that's important to us is making sure that each of the children has a clearly defined space that is theirs. And so 28 is the amount of bedroom spaces that we have for long-term stays. Beyond that, it would be on more of an emergent basis or a more temporary basis within the building as it's currently laid out.
Follow up.
Thank you, Mr. Chair. So do you currently have the authorization on an emergency basis to expand that?
We do not. The authorization we have is for up to 28, whether that's short or long term.
Anyone else? Representative McGrath.
Thank you, Mr. Chair, and thank you for taking my question. So will this go to 30 or this will maintain the 28?
So I believe that the 28 would still expire at the end of next fiscal year. So we would be back at 26 unless this authorization was engaged. And I suspect my understanding from the department is that there would be an ongoing conversation each year to say what we're seeing in the in census trends, what we have for the wait list. Our wait list tends to get engaged very early on in a child's life because it can sometimes be a months-long process for them to be able to leave the hospital. So we do have a little bit of a window into what 6 months from now looks like or what a year from now looks like in terms of future capacity.
Anyone else? Seeing no one else, thank you.
Thank you all so much.
Also signed up to speak is Brendan Williams from NHHCA. Okay, all right, thank you. All right, no one else has signed up to testify on SB 18. Does anyone else wish to testify? Seeing no one, I'm going to close the public hearing on SB 18. The next hearing is scheduled for 10 o'clock on SB 37. So we will be in recess for 6 minutes. Thank you. so. Okay, well, I'd like to reconvene. It's a couple minutes past 10. The next hearing is on Senate Bill 37. Senator Pearl is chairing the Executive Departments and Administration Committee in the Senate right now, but ably sitting in for him is Grant Bossy from the Senate staff. So welcome, Mr. Bossy.
Thank you very much, Chairman McDonald, members of the committee. My name is Grant Bossy. I am Deputy Chief of Staff of the New Hampshire Senate and here to introduce Senate Bill 37 on behalf of Senator Pearl, the bill's prime sponsor. I think this is my first time before HHS this year, so hello to the new members. The bill is a request from the Department of Health and Human Services, which is here today to answer any questions you may have. I'll run through it quickly. Section 1 revises RSA 151.5C to make quality assurance programs mandatory for licensed residential care facilities. Section 2 amends RSA 151.6 to expand the types of residential care and healthcare facilities that may be investigated by DHHS for violations. It also requires the results of those investigations to be posted in a conspicuous place in facilities and requires posted results to include facilities, the services investigated, and the results. Section 3 amends RSA 151.6, sections A through C, to require those facilities to post results of life safety inspections. Section 4 amends RSA 151.16b by removing the words administrative fine. They're already covered in a previous section. Sections 5 and 6 amend the patient's Bill of Rights by replacing the word hospital with the word facility in two places. This allows the patient's Bill of Rights to apply to more types of facilities. Section 7 amends RSA 151.50 by removing the word continuing from the initial education requirements and replacing the term ongoing training with continuing education in the annual training requirement. Responding to a concern of the New Hampshire Hospital Association, the committee made a small technical correction to Section 6, changing hospital to facility in an additional place. Senator Pearl brought in a floor amendment, further refining the language, believes the bill now satisfies the needs of all the stakeholders. The Senate approved it on a voice vote. If you have questions, I would defer to the department or make sure Senator Pearl gets you an answer. Senator Pearl thanks you for your consideration and support of Senate Bill 37. Thank you.
Thank you. So you're not taking any questions, or you'd prefer not to?
If you have some for Senator Pearl, I can get you an answer, but I am not the person that could give you an informed response.
Any questions that Mr. Bossy can bring back to Senator Pearl? Seeing none. Okay, thank you, sir.
Thank you.
Okay, we have several people signed up to speak, and given our schedule, I'd appreciate it if testimony could be limited to 3 minutes. Next up is Kelly Keefe from the Department of Health and Human Services. And Danielle Ambrose, the two of you are coming together, I take it? So yeah, where there's two of you, combined six, a combination of 6 would be fine. Thank you, Ms. Grant.
Good morning, Mr. Chair and committee members. My name is Kelly Keefe. I am the Licensing Unit Chief for the Bureau of Licensing and Certification at the Department of Health and Human Services. And with me, I have Danielle Warboys.
And I'm the General Counsel for the Bureau of Licensing and Certification.
I would like to thank Senator Pearl for sponsoring this bill and Grant Bossy for introducing Senate Bill 37.
Sure.
Oh, sure. Sure. Is that better? Okay.
You need to be directly staring at
that. Okay. All right. Sure. Sorry about that. As this is a department requested legislation, we are in support of it. The intent of this bill is to ensure patient safety and well-being by requiring transparency of healthcare facilities to improve patient care and outcomes and reduce adverse events. Currently, quality assurance programs are optional for licensed residential care facilities in law. The proposed legislation would amend RSA 151.5C to mandate quality assurance committees in residential facilities. Nothing else would change. The details and meeting minutes remain confidential and privileged. Currently, only clinical survey results are posted for public in the law. The proposed legislation would amend RSA 151.6 to require investigation results and amend 151.6A to require life safety survey results be posted to the public as well. The proposed legislation would remove the word administrative fine from RSA 151.16B, the section on civil penalties, as there is already a section on administrative fines. The bill revises the Patient's Bill of Rights by making the reference consistent in Section 21 by using the word facilities rather than hospital. This makes it applicable to all licensed healthcare facilities. The bill seeks to clarify the language in Section 50 by removing the word continuing from initial education, this is in regarding the dementia training, and replace the term ongoing training with continuing education and the annual dementia training requirements. We're happy to answer any questions.
Thank you. Representative Weber.
Thank you. This is a question I wrestle with every time we come up with this facility hospital dichotomy. So if we change the name to facilities, that will also include nursing homes. What else?
Every facility that's required to be licensed under RSA 51 would encompass under the word facility.
Could you just give us a
Sure.
brief rundown of
Yes,
some of the
course.
other ones?
Nursing homes, assisted living facilities, surgical care centers, hospitals, urgent cares.
Thank you.
Yeah, we have 24 different categories, and it would encompass each one.
Anyone else? Representative Hartnett.
Thank you, Mr. Chair. Thanks for taking the question. So mental health facilities, alcohol and drug treatment facilities,
Correct.
it's as broad as
It
we're
covers,
imagining.
yep, every licensed facility.
Thank you.
Anyone else? Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. Were there specific gaps in care that were identified, or is the purpose of this just to bring us in alignment with other states? So I'm just trying to understand the impetus for it.
Generally speaking, it's to provide the transparency. So currently, the public is not privy to any life safety results, which we annually survey every facility life safety code, and any complaints, the public is not privy to any results.
Anyone else? Seeing no one. Thank you.
Thank you.
Also signed up to speak is Judith Jones from New Futures and the Alliance for Healthy Aging.
Yeah.
Good morning.
Good morning. Good morning, Mr. Chair. Good morning, members of the committee. I'm Judith Jones, and I'm the Healthy Aging Policy Coordinator for New Futures. This is a nonprofit, nonpartisan organization that promotes healthcare advocacy. We've been working for more than 25 years to help increase healthcare accessibility throughout New Hampshire. We also lead the policy work for the New Hampshire Alliance for Healthy Aging. We strongly support Senate Bill 37. It takes an important step to provide critical information by authorizing DHHS to post complaint investigations, health and life safety results, and maintain quality assurance programs. These steps bring a level of public exposure and awareness that's critical information that does not currently exist. With regard to residential care facilities that treat individuals with substance use disorder, New Futures has worked throughout its history, especially over the last 2 years, and since the publication of NPR's radio podcast, The 13th Step, New Futures has worked closely with many of you to strengthen oversight and patient protections within our healthcare system. And in this work, we found that few steps are as impactful as better protecting patients as enhancing public awareness. With regard to residential care facilities that serve as assisted living centers, New Futures and the New Hampshire Alliance for Healthy Aging has worked closely with the Long-Term Care Ombudsman and the Department of Health and Human Services. And we appreciate the high quality of work those groups do. Still, far too many patients and consumers really rely on the results of investigations, and these often remain hidden from view. Certainly, these increases in public awareness and confidence in our healthcare system will give patients, families information they need to make informed decisions. And for these reasons, we ask you to support Senate Bill 37.
Thank you. Any questions? Wow, okay, thank you.
Thank you.
Also signed up to speak is Susan Buxton from ALTCO and the Commission on Aging. Good morning. Oh, put your mic on, please. There
Nope,
you go.
there we go.
There you go.
Thanks. Good morning, Chairman McDonald, members of the committee. Thank you for allowing me to speak this morning. My name is Susan Buxton. I am the State Long-Term Care Ombudsman. I'm also a member of the Commission on Aging, and I'm here in support of Senate Bill 37 on behalf of both of those organizations. The State Long-Term Care Ombudsman is an Older Americans Act program, and our office works with individuals who live in assisted living and nursing facilities to resolve problems. We receive also calls from the public. We assist families, we assist providers, and obviously residents living in facilities. One of the questions, the calls that we get frequently is from families that need to select long-term care for a loved one. And they're seeking advice on how to select a facility. And one of the things that we encourage individuals to do is to review the regulatory compliance history of the facility. So there are two types of inspections and two types of areas of inspection. So there's the annual inspection, and then there's also complaint inspections, and those are regarding health issues such as medication administration and other clinical care. And then separately are the life safety, which is such as compliance with conducting fire drills, meeting building safety codes, etc. So the current New Hampshire law, RSA 151, keeps private information for both annual and complaint investigations for inspections for life safety and the complaint inspections for health in assisted living facilities. Under federal law, the results of all inspections and founded complaint investigations are available for nursing homes certified under Medicare and Medicaid. However, assisted living are not subject to federal regulations, and even though these types of inspections are conducted for assisted living facilities, New Hampshire law currently does not require them to be made public. This is a public safety concern. Vulnerable adults and or their caregivers should have access to this information. Imagine trying to select an assisted living facility and you have no way of getting information about whether the building is safe for the people that are living there. So the other reason why I'm very strongly in support is that this bill is that we work closely with the department. We are advocates. We do help to resolve complaints that are filed by people, but we're not regulatory, we're advocacy. And I can tell you that often we work together with the regulation, the Department of Health and Human Services, and we are trying to resolve the issue and move forward. And currently, the way the law is written, the department does inspections, and there are times that I'm aware of the outcome that they have founded the complaint and they have issued a notice to the facility to rectify the issue, but the complainant is never given that information, and it really stands in the way of getting to resolution in the end because The facility isn't necessarily going to share that information. I can't share that information, and the department can't share that information. So you can see where that relationship doesn't move forward and that issue isn't fully resolved unless they really see a change in behavior, and they may not have that opportunity. So for those reasons, I'm here to request your support to pass this bill. I'm happy to answer any questions.
Thank you. Representative Weber.
Thank you. Nice to see you again, and thank you for taking my question. One of the things that, am I correct in thinking that this allows things that have not been posted in the past to be posted and to be released not only to the complaining person, but anybody else who's looking to see what the record of the facility is, but they're not posted unless they are founded. Is that correct?
That's correct.
There is protection here for the facility in case they have somebody who just likes to complain, because of course we know there are people like that. But this protects both the facility and residents and potential families and residents seeking information.
That's correct.
Thank
And that is fair, that you can't really compare two facilities if one has a chronic complainer and so they have more complaints than the facility that does not. It's founded complaints, and that is an important part. Thank you for that question.
Thank
Great
you for the
clarification.
clarification.
Any other questions for me?
Anyone else? I have one. Representative Drew.
I just want to make sure I'm understanding this correctly. Someone can make a complaint about one of these facilities. They submit that complaint. It goes to DHHS. It goes potentially through you, and they never hear back on on what happened, whether or not that complaint was founded or whether or not action was taken to fix it.
That's correct. So our office, we are two separate, very separate entities. We do communicate with families about, with the permission of the resident, the individual, the results of our investigation, but we're advocacy. And so we may say, you know, we're seeing that there's an issue here and here's what we're going to do to help improve it. From the regulatory standpoint, that's compliance. Their information is confidential. So no, the complainant never hears the results of that investigation. Currently, the way the law is written.
I was in the fraud unit at Health and Human Services for 23 years, and we had a similar situation. And if someone made a complaint, a welfare fraud complaint, we could not get back to them and tell them the outcome unless it went to court, and then it was public information. Is that similar to your situation? If it goes to court, then they can find out, right? It becomes
Correct.
public at that point. Because we had strict confidentiality guidelines also. Anyone else? Yes, Representative Tejas.
Thank you, Mr. Chairman, and thank you for taking my question. So I heard quality. So it sounds like, I want to make sure I understand. We're not really talking about creating something like a dashboard for quality. We're talking about just making available, if there's a complaint and it's founded, just having that information publicly available.
Right. That's so if there is a complaint that's founded, then the department issues a notice of deficient practice, a citation, and the facility then is required to correct that deficiency because it's not meeting the regulations, and that would be made public. The department would post that.
To follow up. So it's like with the Better Business Bureau, you look up to see if there's been problems.
Correct.
So you're just looking to make sure a facility you're looking to put your parent in isn't on the list, essentially, right?
What
It's-
exists currently
yeah.
for annual inspections is the facility's required to post it in a conspicuous location. You can also check regulatory compliance in the Office of Professional Licensing and Certification website, OPLC, and it would list the results of the annual inspection. I presume that the department will do the same thing should this bill pass with life safety and complaint inspections, that the public will be able to go to the OPLC website and look up by facility. So you wouldn't have a list of all the facilities, you would look them up by facility to check compliance with regulatory.
Okay, thank you.
Anyone else? Yes, Representative Kesselman.
Thank you, Mr. Chair, and thank you for taking my question. You might not be the right person to answer this, but looking through this, it looks like those complaints that are mentioned would be able to be on the website from this. So I guess my question is there a fail-safe with the department or anything that you know of that would make it so that, let's say somebody doesn't like a facility and just makes a bunch of unfounded complaints, that those wouldn't just show up on the website as a complaint?
The department would have to, they would have to verify the complaint that the facility is not meeting a specific regulation. Kelly? Right, it would have to be founded. And I can tell you that their investigations are thorough. So just because somebody complains doesn't mean it's going to be founded.
Anyone else? I'm seeing no one. Thank you.
Thank you.
No one else has signed up to testify on SB 37. Does anyone else wish to testify? If no one else does wish to testify, then I'm going to close this public hearing. The next public hearing is scheduled for 10:30 on SB 92 FM, so we'll be in recess for the next 5 minutes. Thank you. Okay, I'd like to reconvene and open the public hearing on SB 92FN and recognize the prime sponsor, Senator Cindy Rosenwald. Welcome, Senator Rosenwald.
Thank you very much. Good morning, Mr. Chair and members of my former committee. It's weird to see you up on the third floor. But for the record, I'm Cindy Rosenwald. I represent Senate District 13 in Nashua. And I'm very pleased to introduce Senate Bill 92 relative to information on the live birth worksheets. I consider myself a strong privacy advocate, and I've been working to better protect the privacy of sensitive health info topic. When a woman gives birth in New Hampshire, the Division of Vital Records, which is located in the Secretary of State's office, collects information about the birth so that they can issue a birth certificate. However, the form that is currently used by hospitals and birthing centers also collects and reports to both the Secretary of State and the federal government a vast amount of personal health information. While the Secretary of State doesn't use this information, the Department of Health and Human Services does. I've given you a copy of the form. It's been reprinted since, so it's maybe a little bit out of date. We made a change 2 years ago to defelonize a woman having to report how much she weighed before and after she gave birth and what her alcohol and tobacco consumptions were. There was a felony if she lied. So this form includes a lot of information, including when was her last period? Does she have a sexually transmitted disease? Is she breastfeeding? Did she have fertility treatments? And was it a vaginal birth? All of this information is linked to a specific individual when it goes to state government. It does not include the names when it's transmitted to the CDC, but it does have birth date and birthplace, along with the residential street address, town, county, zip code. So Senate Bill 92 does not limit any of the information that the Secretary of State and DHHS get that is linked to specific individuals. But it does prohibit 4 identifiers from being disclosed with the medical history to the CDC. Those 4 identifiers are the name and the medical record number, which are already not shared, but this is a preemptive prohibition. The street address is not to be shared, but the town, county, and state are. I lifted the language of zip code from current law, but there may need to be an amendment to make it clear that zip code may be shared. And I think that's something the committee might want to investigate, because there are some zip codes that have fewer than 20,000 people in them. And in those cases, HHS doesn't like to use them because it's too small a universe. Finally, the year of birth instead of the date of birth for the parents. And this is okay with the CDC. The baby's date of birth may be still shared with the CDC. A couple of months ago, I participated in a Zoom meeting with HHS, Vital Records, and a number of people from the CDC. And they convinced me this was a critical data element. So the baby's date of birth, but the parents only the year of birth. At the request of the Division of Vital Records, this bill also makes 2 housekeeping changes. It changes maiden name to name prior to first marriage or civil union. And the other change is to align the statutory requirement for reporting the APGAR scores so that it matches up with current clinical practice. I want to note that I've worked with DHHS on this bill. They're comfortable with it. And Vital Records has stated that $68,000 in grant funds may possibly be at risk. I also want the committee to know that at least one other state does not report all of the required elements, and they have apparently received no financial penalty from the federal government. So if you were to look at RSA 332I, it has, since I think 1989, made clear that the information in someone's medical records belongs to them. The provider owns the physical record, but the individual owns what's in it. And it doesn't belong to the hospital, the birthing center, the doctor, or the government. And moreover, 7 years ago now, more than 80% of the voters amended the New Hampshire Constitution to include that granted staters have the right to be free from governmental intrusion in private or personal information. So I believe that releasing a person's patient-identified health information without their consent violates both state law and our Constitution. The bill has an effective date far enough out so as not to force early reprinting of the birth worksheet forms. They apparently print them once a year. So I've given time for that. And I'll just leave you with the thought that it's our job to advocate for the rights of granted staters. We work for them, not the CDC. And my medical information belongs to me. Yours belongs to all of you, not the government. And in the end, it's a constitutional right to be free from governmental intrusion in personal or private information. But it's also a legal right. Happy to answer questions. Thank you.
Thank you, Senator. Do you know what the other state is that you mentioned?
I believe it's Alaska.
Alaska.
I am not exactly sure. And it may be more than one other state.
Okay, thank you. Other questions? Representative McLean.
Just a quick question for clarification. So, you mentioned that it's far enough out that it wouldn't require, reprinting of the birth sheet right now. But I guess I'm a bit confused because I thought the birth sheet was not going to be changed. The only thing was that certain aspects of it would not be shared with the CDC, but would still go to Vital Records and our HHS. Did I misunderstand that?
So you're not. What I should mention is DHHS has decided to remove the medical record information from the birth worksheet. There is no statutory authority currently for that to be reported from the hospital or birthing center to vital records. They've decided they don't use it. They want to get it off of there. So the worksheet would also have to be changed on the issue of maiden name and on the reporting of the APGAR scores. So there are a few changes that would affect the birth worksheet as well.
Thank you for clarifying.
Representative Lucas.
Thank you, Mr. Chair. And thank you for taking my question, Senator. Are you aware of any opt-out provisions that exist right now for mothers in filling out the form?
Oh, man, I have tried. I have, over the past 2 years, tried to both de-identify what is reported to the Secretary of State and run into, well, let's say the first year I got it out of the Senate and the House killed it because HHS came in and said, we're going to lose $10 million in CDC maternal child public health grants. And so the House ED&A said, thumbs down. I did discuss over the years opt-out provisions for that, or even opt-in provisions, but I think the department would have the same reaction. And I understand why this information is useful. It's helpful, very helpful for our Health and Human Services Department to know where are the clusters of Medicaid births? Where are the clusters of premature births? Where are the clusters of babies who are born with abstinence syndrome, withdrawal syndrome? I think it's called. So I understand the public health good for this information, but I'm so conflicted about having people's names attached to it, but I have not been able to get that through the legislature. So this year I took a different approach, which is, okay, state government, I'm not going to get in your way. I'm just going to say, we're not going to share quite so much information with the federal government.
You have a follow-up?
Follow-up, thank you. So,
Long-winded, sorry.
no, not at all. So the medical information that would be used for research, in your view, as part of this process, is that important to retain?
You know, I think it's all helpful information for public health purposes. I guess we could ask ourselves, do we appropriately fund the public health division of HHS so that they can do all this good work? Certainly, if they lost $10 million a year of federal grants, that would really hamper their ability to do anything. I think public health is something like 85% federal funds. So it's not a big, and it might be more, it's not a big general fund expenditure. And we do want to have healthy babies born in New Hampshire. And so to the extent that we know where resources are missing or where additional services might be helpful, I think this information is good. I, sort of on a separate track, am concerned that this division is not located in the Department of Health and Human Services, as it is in just about every other state. And that has to do with Secretary of State not being subject to HIPAA, but they do have confidentiality requirements that are strong. There's never been a breach. So there's not been a will to move it back to HHS because they've made the case that they maintain the vital records for the state, marriages, deaths, births, divorce, all that stuff. So I'm trying to be pragmatic and face the reality.
Thank you.
Anyone else? Seeing no one. Thank you, Senator.
Thank you very much.
Also signed up to speak are Aaron Hennessy and Kristen Martino from the Secretary of State's Office and the Division of Vital Records.
Good morning, everyone. My name is Erin Hennessy. I am the Deputy Secretary of State. Thank you, Mr. Chair, for allowing us to speak today. With me today is our Division of Vital Records State Registrar, Kristen Martino. We're happy to answer any questions you have in speaking with this bill and how it came amended out of the Senate. And I'll just give the floor to Kristen, and she can give you some little background on this.
Good morning. So in working with Senator Rosenwald, we are comfortable with the amendments that she is proposing. The only thing that we had our mind to was any type of federal funding we could get, which I believe was a potential loss of about $60,000 in federal funding if we do not provide some of the information, which would basically be the residential address information and the parent states of birth. This was not something that was...
Okay, could you move the microphone a little closer, please?
Sorry.
You have to speak directly into it.
Okay. Is this better? Okay. So I'll back that up. So we have been working with Senator Rosenwald on this, and we do not have any issues with any of it. The only thing we just wanted to bring before you is just to make you aware that there could be a small financial impact to the department. We rely on federal funding, and part of that is the money that are because of the data that we're providing. We get paid for providing that data. So we'd be a potential loss of about $60,000. As Senator Rosenwald already mentioned, we did attend a meeting together jointly with the CDC, which we did not get very clear answers on. So may is a very strong word. We may lose our funding, we may not. So just wanted to bring that to your attention, and I'm happy to answer any questions that you have.
Do you happen to know, is it Alaska that the other state that doesn't provide the information and suffers no financial penalty?
I believe it is Alaska, and I believe that data was for breastfeeding questions.
Okay, so somewhat similar situation?
Mhm.
Okay, thank you.
Mr. Chair, could I just add to that? I believe the way the amendment in the Senate came through, the zip code was included, but we would request that on line 16 that or zip code would be removed, as the senator mentioned.
Is that line 16?
Yes.
Just zip code, not address, but is it just zip code? Okay. Representative Weber.
Just to clarify language on that, the senator spoke about not including zip codes for zip codes that had less than 20,000, and I know that's language we have used in other contexts at other times. What I'm confused about is when the Division of Vital Records Administration releases information on a birth to the Center of CDC, it shall not include. And so what you are requesting is that if we remove zip code on line 16, you will be providing the zip code to the CDC. So is it okay if I make an amendment saying unless the zip code, No, I mean, you're not, you will be releasing the zip code. So do we need a further restriction about not releasing the zip code if it's a cohort of under 20,000?
Thank you for the question.
I'm sorry, I got tangled up
That's okay.
in what we were releasing and not releasing and how the language went, but
So I think this is the first time our department has heard of the less than 20,000, but I will say that the majority of the zip codes probably in New Hampshire are less than 20,000. So we would have to do, I don't want to say we want to go back to the CDC with this request to find out if there's further grant money that would be at risk if we do not include the zip code. But I'll let Kristen speak further to this.
I would actually echo what Aaron just said. We do have one statute, and I can't recall which one it is, but it does talk about aggregate data is not released for populations less than 5,000. I believe that that's just in our internal statistical file that people can access just for basic statistics. But I can look into this further to see if that's something we could apply in this direction as well.
Any other questions? Seeing none. Okay, thank you. Also signed up to speak are Whitney Hammond and Shari Chalwa from the Department of Health and Human Services.
Good morning. So I am the interim deputy director of the Division of Public Health Services. My name is Whitney Hammond, and I am joined here today by Chawei Chawla, who's our bureau chief for the Public Health Statistics and Informatics Bureau in the Division of Public Health. Sorry, I'm just going to move this. So thank you for giving me time to testify today. The Department of Health and Human Services Division of Public Health is taking a neutral position on the legislation. The department recognizes that the Office of the Secretary of State, Division of Vital Records, is the lead agency on the bill. The department takes its role in protecting sensitive and private health data very seriously, and we're committed to using all vital records as authorized in current statute or under public health authority to help prevent poor birth outcomes, prevent child abuse and neglect, ensure that women and infants receive appropriate and timely care, and that New Hampshire residents have access to needed social services and assistance programs. This goes beyond the Division of Public Health and our use of the data, but the department as a whole uses the data from the birth worksheets for a number of different need-based programs and social services. And so access to the data collected would impact access to those things. The department does not expect any fiscal impact from SB 92, and we have worked closely with the sponsor of the bill, Senator Rosenwald, and appreciate her efforts to protect access to critical data for New Hampshire. We're happy to answer any questions if people have any.
Okay, thank you. Any questions? Seeing no questions. Thank you.
Yep.
Your card said that you had written testimony?
No one else has signed up to testify on SB 92FN. Does anyone else wish to testify? Seeing no one, I'm going to close the public hearing on SB 92FN. We have a 5-minute recess, and then we will convene the hearing on SB 118FN. We stand in recess for 5 minutes.
Good morning, Chairman McDonald, members of the House. Thank you for hearing my bill, Senate Bill 118. I am the senator, for the record, my name's Regina Bertzel, State Senator for District 19, which yep. Better? Okay. For the record, my name's Regina Bertzel, State Senator for District 19, which encompasses the towns of Derry, Hampstead, and Windham. And I'm here as the prime sponsor of Senate Bill 118, which was a request at of the Department of Health and Human Services. First, the bill seeks to amend RSA 167 colon 27A, Roman numeral 2, to adjust the personal needs allowance of residents of nursing homes to reflect their Social Security increases on an annual basis versus the 5-year adjustment that's in current law now. Additionally, Senate Bill 118 makes a $160,000 appropriation to the department to fund certain leave accrual and retention payments for temporary classified staff positions at the Hampstead Hospital and the residential treatment facility. What happened, excuse me, what happened there is while those, the staff at Hampstead Hospital, they were under temporary state employees, and they were given, or they were promised bonuses to stay on. Once Dartmouth Hitchcock took over, they no longer were allowed those bonuses. So this is a payment for the time period that they were state employees and were entitled to. It's a prorated amount that they're eligible for. And lastly, the legislation establishes the Hampstead Hospital Residential Treatment Facility Capital Investment Fund. And again, members of the department are here to answer any other questions that you may have, but I'll try and take some. Thank you.
Good morning, Chairman McDonald and members of the House. My name, for the record, is Wendy Altman, and I am the Bureau Chief at the Bureau of Adult and Aging Services, and I put forward the request for Senate Bill 118 for the purposes of providing individuals who are residents of nursing facilities and residential care facilities served under the Choices for Independence waiver to receive annual personal needs allowance increases versus waiting every 5 years for that increase. A personal needs allowance is a small amount of income that nursing facility and residential care residents are able to retain when the cost of care for room and board is determined where they reside. And currently, the personal needs allowance is updated every 5 years. And with inflation, we wanted to put forward policy that allowed for individuals in nursing facilities and residential care settings to receive that inflation look every year in order to receive that personal needs allowance. And I'm here to answer any questions of the committee related to that piece of the bill that's been put forward.
Thank you, Mr. Chairman. Thanks for taking my question. Do you have happen to know off what the average stay in a facility by a person who would be needing these adjustments?
I currently have information related to the average amount of time somebody is on a Choices for Independence waiver program who may be in a residential care facility, and it's about 3 years. overall across the whole population. I do not have the average amount of time somebody's in a nursing facility currently.
Follow up. So if a person is in a facility for 3 years, it's possible that they would be totally missed by an adjustment if it's every 5 years?
Potentially, yes.
Thank you.
I was just wondering, because it doesn't specify in statute, what index the commissioner uses to make the determination on the cost of living adjustment. If you know, if you don't know, fair enough.
It's based on the Social Security cost of living adjustment.
Okay, thank you.
Any other questions?
My question is, so if there's a raise every year, then the facility or choice of care would get a little, they would get to keep a little bit less. So it would have a financial impact on them, though, I mean, it seems fair that if the Medicare payment is going up, I mean, the Social Security payment's going up, that the residents should get some benefit from that too.
Yes, similar to other publicly funded programs that look at income eligibility or adjust based on inflation, rent, or such as in public housing, things like that. When the COLA or the Social Security index is adjusted, all of those other programmatic requirements get adjusted with that.
What is the amount now, and who provides funds to the patient? Is it the nursing home?
I would say it's usual and customary for nursing facilities to take the room and board component of that and then leave the account, a patient account, for individuals to have that amount. And currently it's $74. And they use that for covering things such as, getting their hair cut, or going to a community event, things like that, in order to be part of the community. And
That's $74 per month.
yes. Sometimes that can be to pay for cable or other communication access or things like that, based on their personal preferences, that aren't covered.
Anyone else? Seeing no other questions. Okay, thank you.
Good morning, Chairman McDonald and members of the committee. My name is Marissa Henn, Deputy Commissioner at DHHS. I am joined by Nathan White, our Chief Financial Officer, and want to speak specifically to the amendment regarding Hampstead Hospital that Senator Birdsell mentioned. So just briefly to reiterate, Hampstead Hospital and Residential Treatment Facility has gone through several phases since the state took ownership of that facility and campus in 2022. And so initially we had a private clinical contractor providing services. It then transitioned to Dartmouth Health in partnership with the state. And now we have moved into a lease model that where Dartmouth Health is assuming both operational and clinical leadership of the hospital, which Nathan will speak to in a minute. So what this amendment does is it helps those employees who accrued time during their relatively brief time, but as state employees, to actually receive the annual leave for which they for which they worked many long hours. In addition to sort of being the right thing to do, it's also important to know that the fact that this amendment has been brought forward has been a really important aspect of retaining them under Dartmouth Health's leadership. So when it comes to achieving mental health system improvements and not having kids boarding in emergency departments, it comes down to staff, and to keep those staff feeling engaged and cared about, not just by Dartmouth Health, but by this state, it's important that they are recognized for the time that they accrued. The other piece of that is annual bonuses. There were a few individuals, like fewer than 5, who were due annual bonuses when Dartmouth Health took over. And so this would also honor those couple $1,000s per person bonus, recognizing the hard work of these people serving vulnerable New Hampshire youth. So those are the two parts, and Nathan will speak briefly to the third part of the amendment that also helps in the sustainability of Hampstead Hospital.
Good morning, Chairman McDonald, members of the committee. Nathan White, Chief Financial Officer with the Department of Health and Human Services. The third section of the bill before you, it establishes a dedicated account. And the reason that this is before you is there is a unique provision in the lease agreement that the state entered into. This was approved back in December of 2024, and we officially closed in February of 2025. And there's a unique provision in the lease whereby if Mary Hitchcock Memorial Hospital invests, it makes a capital investment in the facility, then the state is obligated to make an equivalent dollar for dollar investment up to a maximum amount of $3 million. The lease agreement, the initial term is 7 years, and after 5, we'll have discussions as to whether we'll renew or not per the terms of the contract. But because there's an obligation included in the contract, it's very unique. It is not standard by any means. But because that's there, the department needs the capacity in order to respond and pay that and address that liability in the event that Mary Hitchcock makes that investment. So the purpose of the dedicated fund is to take revenue for the next biennium and put that aside so that we have that in ready and waiting depending on when that investment takes place. Any amount in excess of that $3 million, it requires a report to the fiscal committee. Based on the lease amount that is set, it's a little less than $1.2 million each year in the next biennium. We wouldn't necessarily we wouldn't see any reason why we would exceed that $3 million cap. Again, that cap aligns with the lease agreement. One thing that I certainly would just want to raise for consideration is we're currently working with Gopher, and we're looking at some of the ARPA requirements, and we would just request that no decisions be made yet, because we want to make sure that because we purchase Hampstead Hospital with ARPA funds, that we make sure that any of the revenue and any of the state law surrounding that addresses unique U.S. Treasury rules. We're actively having discussions. We started those about 2 weeks ago with Gopher after they identified something that we may need to address. So we're actively working with them towards that, and we may need some modification to the language to make sure that we're compliant with U.S. Treasury rules relative to revenue derived from a capital investment used with ARPA funds. So that's a very quick synopsis. More than happy to take any questions.
Any questions? Yes, Representative Weber.
Mr. Chairman, this is really more a question for you than for the people who are testifying right now. But if we are to hold this bill, am I right in thinking that this bill is likely to be an early bill?
It's our own
So
bill.
we have very little option but to pass it along if in fact we're going to react favorably. But at that point it would go to the Finance Committee, I am assuming, and they would be the more appropriate place to take action on that anyway, it would seem to me. Is that not correct?
That would make sense, sure.
Okay.
I mean, the deadline for the early bills, I believe, is May 8th, if I remember. So we've got ample time.
We've got
terms
some
of-
time, but
in
not.
terms of, right, in terms of what we do, but yeah, but it's got to go to finance, and they'll, again, as Representative Weber indicates, they're better equipped to deal with finance, the finance side of this, so. Representative Mazur.
Thank you, Mr. Chair. Thank you for taking my question. You mentioned that, and correct me if I'm wrong in anything that I say, Hampstead Hospital is now run by Dartmouth Hitchcock. And you mentioned the bonuses. So why didn't Dartmouth Hitchcock cover that as part of the contractual agreement in the transition?
Yeah, it's a good question. So correct, Dartmouth Hitchcock is now operating all aspects of the facility through this lease model. The state, just so you know, still retains oversight. We are still the owners of the campus and of the grounds. We also oversee this lease for which they have to maintain services and quality, and we have a joint operating committee to help co-manage day-to-day things. So it's a significant role, but we didn't sell the whole farm. In terms of the question of the payments, so essentially when we moved from that very first model of bringing in that private entity when the state first bought Hampstead Hospital, essentially the state had made a commitment that for those employees that stayed on, we would assume that responsibility because they were becoming state employees. So I guess what I'm trying to say is the bonuses were actually promised under the private entity that had come in. I should have been more specific. And so we had paid out most of those people as they approached 1 year, but a few of them, their 1 year anniversary was right after we were closing with Dartmouth Health. So they just missed the cutoff. In terms of accrued time, that was just accrued time as a state employee, just as most of our employees accrue time. So the reason that we didn't hand it off to Dartmouth is because we had made that commitment to 140 out of the 145 staff. These are just the remaining 5 for whom the state has, we feel, a sort of ethical responsibility, and didn't feel that was necessary to pass on to Dartmouth Health.
Follow up.
Yes, thank you. So you mentioned there's still 5 people that need that.
I don't know if that's the exact number. It was a very small number.
And do you know the
who-
dollar amount on those 5 people?
It's in total it's 160,000, but that includes both the accrued vacation time and the bonuses together.
Thank you.
Yeah.
Any other questions? Oh, Representative Hartnett.
Yeah, thank you, Mr. Chair. Just a quick question. I'm guessing it's that joint operating committee that would be the decision point for any capital improvements? Okay, but
That's right.
we maintain the final say there, our building?
So because of the way that in order for this hospital to be credentialed and to be approved by the Centers for Medicare and Medicaid Service, you actually have to have a single point of accountability. So this was very thoughtfully designed with Department of Justice involved, and of course lots of attorneys with Mary Hitchcock and Department of Health and Human Services. Essentially, Dartmouth, the answer to your question is that there is a joint operating committee, and things like capital and the funding that Nathan mentioned all have to go through that group. Metrics, quality, lots of operational components. Ultimate say does rest with the Mary Hitchcock board of directors. And so it's a careful balance between the state needing to give, both for legal reasons and practical reasons, Dartmouth Health the ability to run the hospital as they run hospitals, but also gives us the ability to make sure, in particular, vulnerable youth and families are being well served. So it's a balance.
But it's theirs.
It is the final say in the operations of the hospital rests with them. We do have many. I won't bore you with details. If we had concerns about whether or not Dartmouth was following the requirements of their lease or issues arising, we have many mechanisms with which to take action, including the Joint Operating Commission.
Thank you.
Representative McKay.
Thank you, Mr. Chairman. Could you give us a very brief resume of what Hampstead Hospital does in relationship to New Hampshire Hospital?
Great question. So Hampstead Hospital has existed for just over 50 years. I think they just had their 51st anniversary. For the vast majority of those 50 years, they were a private for-profit hospital that did an array of services, but were known for their children's psychiatric inpatient care, as well as a lot of substance use treatment, for not just for kids, but also for adults. The state used to care for children at New Hampshire Hospital, both on that campus and then specifically within New Hampshire Hospital. There's a long history about that, but essentially in 2019, a decision was made in part to create more beds for adults at New Hampshire Hospital, to essentially move to a contract model with the then private Hampstead Hospital under Hampstead Outlook, and to contract with Hampstead to care for New Hampshire kids. That hospital decided they would be going up for sale in roughly 2020, 2021, and the state didn't want to lose its sole psychiatric facility for kids. So we decided to acquire that hospital. And as I said, since that time, roughly 2.5 years ago, it's gone through a few different phases now with Dartmouth Health at the helm, much as they do at New Hampshire Hospital. However, in the Hampstead case, Dartmouth Health has not only the clinical leadership, but also operational responsibility. Does that answer your question? Oh, and in terms of services, it's mostly psychiatric inpatient care. So these are kids who need treatment, who are very acutely ill, who often show up to emergency departments, not safe in terms of potentially causing harm to themselves or others, who need the highest levels of clinical care. Usually their stays are about 1 or 2 weeks. The state also opened a residential treatment facility, which essentially is sort of a step down. These are youth who often have very severe adversity and trauma, who don't need to be at that highest level of hospital level care, but need to develop additional skills and coping mechanisms before they can return to community. So it's both right now a residential treatment facility, and it is a roughly 40-bed inpatient psychiatric hospital for children.
Follow up. What I'm interested in is how the two hospitals work together.
Sure.
And whether there are administrative structure for both hospitals, or is one separate from the other? In other words, we've had a serious problem at New Hampshire Hospital for bed capacity, and we had that terrible problem of people being in general hospitals, which I understand is much better now. But that I'm curious as to how those two hospitals work together.
Yeah. It's one of my favorite topics, but I'll be very brief, which is to say New Hampshire Hospital is actually a state-run facility. So the CEO there, the whole C-suite, all of them are colleagues in Department of Health and Human Services leadership. The clinical leadership, so the prescribing practitioners, the psychiatrists, they are Dartmouth Health employees who engage contractually with us to co-operate the clinical aspects of that hospital under that DHHS leadership. The nursing, social work, all of them are also state leaders. So it's kind of this quilt work of both state and Dartmouth, but it is state C-suite at New Hampshire Hospital. Hampstead Hospital is a little different, where, as I said, Dartmouth is not only employing those prescribers, but it is also employing every nurse, every social worker, every custodian, every person who works in the walls of that hospital is a Dartmouth Health employee, and Dartmouth Health's board assumes responsibility for things like accreditation and the financial responsibility for the risk that the hospital, they bill insurance, whereas at New Hampshire Hospital. So I'd say the similarity is the state is deeply involved. Both facilities are required to be really working not just on individual care of patients, but on building a robust mental health system that prevents the type of boarding of patients that you described. Both are led by very mission-driven teams and have strong commitments to the underserved, but the actual management and financial responsibilities as they relate to DHHS are a little bit different.
Thank you.
Yeah.
Any other questions? Seeing none. Okay, thank you. Also signed up to speak is Susan Buxton from ULCO and the Commission on Aging.
They did. Jim's question might have misled.
No, I did.
Good morning, Chairman McDonald, members of the committee. Again, I'm Susan Buxton. I'm the State Long-Term Care Ombudsman, and I'm also a member of the Commission on Aging, and I'm here before you this morning on behalf of both of those organizations in support of Senate Bill 118. My primary interest is in the personal needs allowance. and in my written testimony, I've talked a little bit about our work as ombudsman in helping individuals who live in assisted living and nursing homes. And we frequently hear from them how difficult it is to stretch that personal needs allowance. $74 a month is they're allowed to retain from their income for their personal needs. And it sounds, personal needs, what do they need? Well, when you're living in a nursing home, it used to be that you got a telephone and you got a television, you had your meals. So that personal needs allowance was kind of for additional items. But I want to remind you, and I'm here today on behalf of those residents who would, if they were here, tell you that it's not enough, the $74. And so please, give them the at least that annual increase. They're using that money to pay for a landline or telephone. If they want to have a television, they have to pay for cable. In addition, their clothing, their personal care items, haircuts. More and more we hear from individuals that they're using personal needs allowance to supplement the food because they don't find the food meets their needs. They may have special likes and dislikes, or they just don't find it palatable. In addition, the small things like buying a birthday card for their children. So $74 is, again, on behalf of the residents, they would tell you it's not enough, so please give them the annual increase. I think Representative Lucas made a good point when she asked, or many of them don't see that increase. They're not there for 5 years. So I'm happy to answer any questions.
Thank you. Any questions? Seeing none. Okay, thank you. Also signed up to speak is Judith Jones from New Futures and the Alliance for Healthy Aging.
Now we're close to afternoon, so good afternoon, Mr. Chairman and committee members. Again, I'm Judith Jones on behalf of New Futures and the New Hampshire Alliance for Healthy Aging. And I want to just build a little bit on what the long-term care ombudsman said. And when we tick off the list of what residents need to spend $74 on, would just ask the question, in a 5-year period, do you think that the costs for a haircut, for clothing, for snacks, for an outing, for telephone, cable would increase over the 5-year period? And we know, just living ourselves, that the answer to that question is absolutely yes, as we all struggle to meet our own daily needs. And if you think of the environment that an individual is in and ask the question, is enriching that person's life important? Is something like buying a birthday card or being able to purchase a snack or having a special meal that you've always had that you can no longer have? So just wanted to ask that question and really leave you with that question and ask you to support with regard to the personal needs allowance, Senate Bill 118. Thank you.
Thank you. Any questions? Okay, see no questions. Thank you. No one else has signed up to speak on SB 118 FN. Does anyone else wish to speak? Seeing no one, I'm going to close the public hearing on SB 118 FN. Our next hearing is scheduled for 1 p.m. on SB 119 FN. We will be in recess until that time.
I feel like these would be bills we could all agree on.
Oh, yeah. I'd be surprised. I haven't heard anything that's,
There's some advocates. I just got a
Good afternoon, everyone, and welcome back to the House Committee on Health, Human Services, and Elderly Affairs. Our next hearing is on Senate Bill 119 FN, and Senator Gray, the prime sponsor, is here. Welcome, Senator, and thanks for being here.
Thank you. My name is James Gray. I represent Senate District 6, which starts up in Alton and Gilmanton, comes down Route 11 to Rochester and Stratford. I like to save money. Okay, and Senate Bill 119 is an effort to do that. My wife loves to shop at Hannaford, and 9 times out of 10, if there's a Hannaford brand, I pick the Hannaford brand up. But you know what? Sometimes that national brand has a coupon, and sometimes that national brand has a discount, sometimes it's just on sale. And that's exactly what this bill does. It says, hey, you don't have to buy generic if the national brand is cheaper. Buy the one that's less expensive. That concludes my testimony.
Wow, that may be a record. Are there any questions for Senator Gray? None? Oh, Representative McGrath.
So, this is just for Medicaid, and do they negotiate with the drug companies for prices?
The Health and Human Services people will come up and answer all those detailed questions that I believe that they do, but again, you know, they'll have more of the details than I would. There is a similar bill that has to do with Department of Corrections because there's a separate statute where they purchase drugs. So that should also be in front of you guys somewhere, or either your committee or the appropriate committee that the speaker has chosen.
Okay, thank you. Any other questions for Senator Gray? Okay, thank you.
Alrighty.
That was quick and easy.
And John, didn't I do exactly what I told you? Okay.
Okay, next up are Dr. Jonathan Ballard and Mr. Henry Lipman from the Department of Health and Human Services.
First. For the record, Henry Lipman, the State Medicaid Director. In terms of the Medicaid program, the current statute requires us, and I loved Senator Gray's analogy, always requires us to buy the store brand, even if the name brand happens to be cheaper for us. And so what we're trying to do is correct for that. Our actuaries work with us, and we expect in state fiscal year 26 to save 1.1 million because it takes some time to implement. In state fiscal year 27, it'll be 3.4 million, and in state fiscal year 28, we'll keep on increasing up to $4.5 million. Yep. So that's in general funds, and the reason is that, again, using Senator Gray's analogy, sometimes the Medicaid program, through its special purchasing, gets coupons where in effect, a rebate that makes the brand name cheaper than the generic. And it isn't always the case. We're asking for the discretion to be able to, where it is a lower net cost to the Medicaid program, that we be able to take advantage of that. And that's the sort of the first part of the bill. The second part of the bill, I'm going to let Dr. Ballard speak to.
Good afternoon, Mr. Chairman, committee members. My name is Jonathan Ballard. I work as the Chief Medical Officer at the Department of Health and Human Services. The second half of this bill deals with an aspect of over-the-counter medications versus the prescription medication. prescription medications, we're required to, as a state Medicaid agency, to have a preferred drug list, a preferred medication that we do not implement prior authorizations or utilization management techniques to try to reduce its usage and push the usage of a medically equivalent but cheaper medication or product. Many times, though, the pharmaceutical companies will take a product that's a prescription version, go through the additional studies, or that medication's on the market for a long enough period of time that the FDA then allows them to take it over the counter. Once it's over the counter, it oftentimes price goes lower than when it was a prescription version. The prescription, then we're left at the state Medicaid agency, and all insurers were left paying for a medically equivalent, higher cost prescription drug in many situations. So what this bill does, it allows us to look at the cost to the Medicaid program specifically and write a standing order. This would be my standing order to all the pharmacies, allowing a Medicaid beneficiary to obtain the lower cost equivalent drug. And at the same time, we could then implement a prior authorization on the prescription version. We're going into the allergy season right now. People are starting to have their sneezes and dripping eyes and such. That's a prime area that you could think of. So there are over-the-counter medicines now that many people utilize. Zyrtec, Claritin, there's several different ones. There are still prescription versions of these medically equivalent drugs, Zizal, different ones, very expensive. But we're required to have a drug being a preferred drug and covered a drug at least in all drug classes as a Medicaid program. So this allows us to have the flexibility over time to develop different strategies to have the lower cost medically equivalent drug available to the beneficiaries. So it's all designed to save money and make sure that we meet the members' needs.
The savings that I related earlier were adopted in the governor's budget and in House Finance Division 3, just as a additional piece of information.
Thank you. Any questions? Representative Polazov.
Thank you, Mr. Chair, and thank you for taking my question. So can you explain me better about drugs being medically equivalent, and if pharmacists have any flexibility for personal reactions for patients if drugs have different levels of contaminants during production or any other issues when pharmacists may decide otherwise?
Representative Polazov, that's an excellent question. Yes, we allow it through a prior authorization process that to be a exclusion. It's an exclusion now. If the provider writing the prescription and the recipient did not want that medication to be the generic now, they can appeal or go through the prior authorization process stating why that is. There's a common drug that's a blood thinner called Coumadin. It also has a name of warfarin, and sometimes you don't want to go back and forth on those drugs, but even though the generic is available in the preferred drug, you can request the non-preferred and provide the reason why. It's just not automatic in the system set up. This probably makes me pause to think that I probably should stop and explain the difference between what they call a legend drug and a non-legend drug. A legend drug is a drug that requires a prescription. That's a process the FDA goes through to say a medication has enough risk involved with it, it has not been on the market long enough, it's unstudied potentially to be over the counter. And a non-legend, which is an over-the-counter medication, has less severe side effects, it has additional study, it's not restricted by practitioners prescribing, and it's all determined by the FDA. So what this bill does is only allows me to write standing orders for the non-legend prescription drugs, the over-the-counter drugs, not prescribing things that need individual tailoring or individual concerns as if I was treating the patient directly. So it's a lower risk prescribing something that's over the counter, but making it possible that it can be processed through the prescription drug um, uh, hardware, the prescription drug technology that allows Medicaid to cover it.
Anyone else? Representative Weber.
So you touched on this, but am I right in thinking that this would allow things like, I used to get a prescription for fluticasone, and then after it had been used for heaven only knows how many years, all of a sudden there was an entire wall of Flonase at my local pharmacy, and a huge rollout, and now you can buy it over the counter, and this would just allow you to write a standing order so you don't have to do the prescription formula? It's the same thing
That is
as
the
far as
same.
I understand. I mean, it used to be Flonase or the generic through the prescription, and now it's
And in
just what you
Medicaid-
pick up.
Yes, Representative Weber. And in Medicaid now, we actually have an inhaled steroid that's more expensive. That is the preferred drug than Flonase. So this would allow that cheaper option. And there are no head-to-head studies on that example between one drug in another class or in the same class to say one is better than the other. And that's actually true among most medications, as probably Representative Woods would attest to.
And could I have a follow-up
Sure,
to that?
follow-up.
And isn't it true that for some people, one formulation just works better than a different formulation? I used to think that it was kind of like complete science experiment where pill A, condition B, and you have result C, but that doesn't work. People are really different, and some respond better to one formulation or one type of drug than another.
Representative Weber, you're correct again. I think that gets into the art of medicine, and we do not and have no plans to get into the relationship between a patient and their prescriber. If their prescriber wants a particular medication, they would simply fill out the prior authorization to say why they're getting the more expensive, and it is reviewed. We do have medical manager. We have doctors that review that in the Medicaid program that we contract through the managed care organizations, and that's their job. That's what we pay them to do.
Representative Woods.
Thank you, Mr. Chair, and thank you for taking my question. It sounds like this is a very good program, and there are obviously some guardrails you've put in place. Would you comment about, do you have any special guardrails for medications that have a narrow therapeutic index, or what's classified as FDA calls a group of medications that have narrow therapeutic index? Is that included in here somehow? I don't see anything where it would be specifically brought out, but would be very crucial for things like thyroid medication is a narrow therapeutic index medication. Can you comment?
I can comment in that those are not medications that are over the counter.
Yeah.
And so that would not apply to this situation.
So, all right, so you just.
Representative McGrath.
Just for some clarification, so if I were to get a prescription today for Claritin, I can bill Medicaid for over-the-counter Claritin. And the computer will either allow it to go through or not go through. But we bill OTC meds all the time. So I'm like trying to figure out what the difference is as far as, so then the standing order, that's only for the pharmacist to switch from a doctor's order to a standing order, or is the patient able to come in and request an over-the-counter med with a standing order?
Thank you, Representative McGrath. There are a few over-the-counter medications that we do process that way. They're mostly for children. I don't know of any for adults. Thank you. So when we determine that there is a particular situation where there is a medically equivalent drug or therapeutically equivalent, and that it's interchange, exactly, and that it's lower cost to the state. We take into account our rebates that are coming back to the states, not just simply the drug price. In that situation, we will plan to provide a standing order that the Medicaid beneficiary can access that medication. Now, that beneficiary can come into the pharmacy and ask for it. What I would expect will happen is that there may be a prior authorization for a more expensive product for the state that the doctor has prescribed. And when the patient arrives to the pharmacy will inform them that there may need to be a prior authorization, which is a request back to the physician to verify that more expensive product is necessary for that patient. What I would expect to happen would be for the pharmacist to notify that patient that we have a medication here in that drug class that you can access through payment from Medicaid.
Follow up.
So is the standing order to go from a generic to a brand name medically necessary because it's cheaper?
No, that's the first part of the bill. The brand name, because it's cheaper, is first part of the bill. This is the second part of the bill about the standing order is about over-the-counter product being cheaper.
So
Follow up.
I guess I don't understand how you could just allow it to go through the billing. As long as it goes through the billing,
In order for the billing processes to happen, there's a few things that have to be attached from the pharmacy staff to do. It has to have something called an NDC number, or a National Drug Lookup number, that's on the over-the-counter product, and then you also have to have a prescriber in order for it to be billed Medicaid. In this situation, I will be the prescriber. My identification number, my prescriber number, my license to prescribe medications in the state of New Hampshire will be attached to that medication for that Medicaid beneficiary. It's an over-the-counter medication, so that's why I feel like it's lower risk. But as a prescriber, and it's already freely available to them if they were wish to choose to pay for it. But we know many of the Medicaid beneficiaries would have difficulty accessing a drug if they would have to pay the over-the-counter price. But that drives them many times to get a much more expensive product for the state through prescription.
Representative Weber.
So to follow up on that question, what I'm understanding is that your standing order simply allows a Medicaid patient to go and pick up at the pharmacy the Claritin or Flonase or whatever it is that they need, just as somebody who would be private pay or can, only it will be billed to Medicaid under your provider number. Is that what's happening here?
Yes, that could be an example.
Okay.
And the alternative would be them going to the cost involved in them seeing a provider and and for the visit to the Medicaid program, and the cost for the actual drug that's a prescription drug. So you actually have two double savings there: the visit and the cost of the prescription drug.
Representative Palazzo.
Thank you, Mr. Chair. Thank you for taking my second question. So if we make it a law, it will be legal. And so why do we need page 2, line 10, that last paragraph, waiving all criminal and civil liabilities? What situation does it look to address?
Thank you. Excellent question. That language was specifically lifted under the same. There are a few examples in law today for standing orders. There's one around naloxone or Narcan, and that this is the language directly lifted from that allowance to prescribe that medication. It protects the state legally and financially should there be some error that happened. So I mean that's what it does.
Representative McGrath.
I just want to clarify again because I'm wrapping my head around it. So any Medicaid patient can go into a pharmacy and get the over-the-counter meds, medical supplies, and laboratory tests on a standing order and have it billed to Medicaid?
In the event that that specific situation, supply, medication was deemed to be cheaper for the state and medically equivalent in that narrow instance.
I guess the larger purpose of this whole bill is we understand from, looking at the state's budget situation, how could we improve the efficiency economically of the program while still providing the same benefit to patients. And, where we can buy a drug with rebate and it's less cost than a generic, it doesn't make sense to pay more. And in the case where after review, it's not like it's wide open, will be based on our medical director and the department's review of the situation as to whether it makes sense to put a particular OTC, over-the-counter drug, in that fashion. So what we're really trying to do is, understanding there's less dollars to work with, particularly in the general fund. We're trying to reduce the general fund obligation while providing the same value to the patient. I know you're dealing with budget issues on the House side, and I think this is a win-win that we can save money for the state and we can still provide the same service. I think that's what we hope to accomplish in government, is to be able to gain efficiencies where there's obvious opportunities to do so. And I think we've identified one, and we've worked with our actuaries to quantify it.
Thank you. Another follow-up?
I don't feel like I've gotten to the bottom. So it will be up to you, not the pharmacist, to determine if there's a cheaper medicine. So let's say the Flonase example. So you're going to put a standing order out. Does the patient need a primary care doctor to prescribe it first? Once you determine the Flonase is cheaper, you'll put out a standing order, and then the pharmacist will know that anybody who comes in on Medicaid can ask for it and get it. I'm still not getting the full service.
Again, thank you for that follow-up. That provides some clarity to me in your questioning. It can be done in different ways. In the standing order, you can put specific requirements of the allowance and use cases for that medication, so that we can actually put in there that in the event that a prescription is issued for a drug in the same class, this can be prescribed. But we have not got into that level of detail, nor did we think that you needed legislation to do that. What it does do is allow, as you said, a prescription or access to that over-the-counter product. And now I don't know that Flonase, we have not evaluated any particular case use, if that drug will be cheaper than the over-the-counter equivalent product, prescription equivalent product. But yes, if the Medicaid beneficiary came into the pharmacy and this evaluation happened and we determined that there would be a savings to the state in net, then they would have access to it without another doctor. Yes. Now, if we saw, we look at this very closely, and prescription volumes and cost, everything. If we saw, though, this was a net cost to the state and was not a net benefit financially and medically equivalent, then that would be part of the calculation of whether or not we would allow that situation or not from a Medicaid aspect.
Other questions? Representative Lucas.
Thank you, Mr. Chair. Thanks for taking my question. How long would this deliberation require to make the decision when the patient walks into the pharmacist? And
So this happens today. This would be nothing. Nothing there would change at all. As far as prior authorization time limits, federally, CMS, the Center for Medicaid Medicare Services, has requirements around what is the time limit on prior authorization limits that and so I believe it's 3 days maximum, but there are some cases where it has to be made within 24 hours. It depends on the different situation for which drug it is. But this bill does not address that matter at all. That's a federally regulated aspect of turnaround time for when a prior authorization is required.
Follow up. So you don't anticipate that this would extend the time before the patient could actually have the medication in hand?
No, I would think it would do the opposite. In most situations, it would be if the patient was there and they needed the medication, they could run it through the prescription system that at that moment and issue that medication then.
Thank you.
Thank you. Anyone else? Representative McGrath?
So unfortunately, there are people who abuse the system. So we had somebody who was getting prescriptions for 3 years for smoking cessation products and on Medicaid. This was years and years ago, and selling them on the street. So let's say that, I mean, it could increase the costs if people realize they can, without a doctor, come in and get certain expensive products. Maybe they're cheaper for the state if they had a prescription. Have you talked about the fact that that's a possibility?
Yes, thank you for bringing that up. We actively use quantity limits in that situation. So that could be an aspect of this. We could put a quantity limit of once per year to avoid any type of situation that you're describing. But that's a lot of things that we've thought about, but we didn't put into the legislation itself to put safeguards and around the program. We have a whole host of program integrity aspects of the Medicaid program that look for fraud, waste, and abuse, and we have found some over the years and have, I think, improved the situation compared to what you were talking about from years ago.
Other questions? I think that's Mr. Lippman.
I'd just like to make one other remark. Just another contextual thing is that the medications in the Medicaid program today represent about 31% of the medical spend. And so, in terms of trying to control that cost, as well as making sure that the latest innovations that can, the biologics and things like that have become available, or gene therapies for children where there's remarkable impacts, we're trying to find areas where we can gain economies and efficiency so that we don't have to withhold services that have value to the residents of New Hampshire. And I think this is a really important thing that I plead for as the Medicaid director in terms of trying to, balance the interests of cost and access. I think it's an important tool that we have, and would encourage you please to pass it.
Okay, thank you. Any final questions? Representative Wood?
Thank you, Mr. Chair. Thank you. I'm bringing up this point again because I think I may have misstated my question, or you may have misunderstood my question, and that's to do with narrow therapeutic index medication. You said it, and the comment, I think I recall your reply, but it only applies to over-the-counter. But if you look on line 18, what's labeled Section 5, pharmacists shall substitute generically equivalent drug products for all legend and non-legend prescription paid for by the department unless the prescriber practitioner specifies the brand name drug is medically necessary. So the guardrail is that, in fact, for narrow therapeutic index medications, the pharmacist is not monitoring it. The prescriber, its onus is on him to understand that he is prescribing a narrow therapeutic index medication. So that's where the guardrail is. Is that correct?
That is correct, sir.
Okay, thank you.
Okay, gentlemen, thank you. No one else has signed up to testify on SB 119FN. Does anyone else wish to testify? If not, I'm going to close the public hearing on SB 119FN. The hour is now 1:34 p.m. and we have scheduled next SB 202. And I'll recognize Senator Prentice, who's here, and welcome her to the table.
Good afternoon, Chair McDonald and members of House Health and Human Services and Elderly Affairs. For the record, my name is Sue Prentice. I'm from West Lebanon, New Hampshire, the state senator from District 5, representing 15 different communities. I am here today in introducing Senate Bill 202, and this is as amended in the Senate. So the Alzheimer's Association had approached myself, as they have approached other legislators and legislatures throughout the country, to find or to identify different ways, including emergency medical services, to raise awareness around the identification, the proper management of Alzheimer's patients. This isn't necessarily medical management. This is largely, it's recognition and, situational operational management. So when they approached me, what I wanted to do, instead of putting this as a training requirement, because we have very specific already in rule requirements for certification and recertification, was use the process that the legislature established. But in order to get there, the first two things which this bill puts into place is, number one, creating a seat on the Department of Health and Human Services has an Alzheimer's subcommittee. And when I looked at that, it was obvious to me that there was a public safety representative from law enforcement, but there wasn't an emergency medical service provider on there. So it seemed to me that if we're going to be creating, awareness across the board in public safety, that it would make sense to put an EMS representative on that committee. So that's the first part of the bill. The second part of the bill takes almost the equivalent over at Emergency Medical Services. They have an EMS and Trauma Services Coordinating Board, which are representatives from all different disciplines that intersect in emergency medical services. The Heart Association is there, the Organ Bank is there, the Hospital Association. So it gives you a sample. It's actually it's a rather large group because there's so many intersections. So I'm proposing that we add a representative from the Alzheimer's Association to be part of that committee. So we've got two different places which are in this bill that would bring EMS representation on one and Alzheimer's representation on the other, in order to make sure that we are raising the appropriate awareness around how the interaction and work of emergency medical services impacts this particular important set of our patients. And if I may say, it's not in this bill, but I just want to give you a very brief bit of background that we have a system already in place that the legislature put in place years ago that says that when you are going to create care-related protocols, there is a body of physicians, the EMS Medical Control Board, established in RSA 153A, that actually writes those care protocols. And within those care protocols, there are different categories. And one of them is medical operational. So I identified that and then went and met using the system that's already been set up, went and met with them, and I brought the Alzheimer's Association with me, presented our case, and have an agreement that they are going to roll this in to their protocol making process. They run it every 2 years. So this has been agreed to, that they're going to add this to their medical operational protocols. So here I'm looking to create the awareness and just cross the representative bodies that are established in statute to make sure that EMS and public safety are equally represented in these groups on Alzheimer's. And I just wanted to assure you that I use the system that the legislature put in place to put the operational medical side of this into play. And with that, I think I've covered everything. And there is no fiscal impact here. I am going to conclude my testimony and take any questions. that you might have. And if I feel like I'm a little bit on speed dating today, so okay, I'm going to slow
And
it down.
we know there's a lot going on.
Isn't there? Yeah. Thank you, Chair.
Representative Mazur.
Yes, thank you, Mr. Chair. Thank you for being here and answering my question. I think it might be an easy one. Do you know how often this subcommittee meets?
Subcommittee, I think, so thank you for your question. Jenny Horgan, who was here from the Alzheimer's Association, can tell you exactly, but I believe it's every other month. But I just want to be sure, so I'll
Okay.
ask her. The EMS side,
Mm-hmm.
they also meet every other month, so they meet at a minimum of 6 times a year for the EMS side. Yeah.
Any other questions for Senator Prentice? Seeing none. Okay, thank you.
All right, I'll see you a little bit later this afternoon. Thank you so
Okay.
much.
Also signed up to speak is Jenny Horgan from the Alzheimer's Association.
Thank you, Mr. Chairman, members of the committee. My name is Jenny Horgan. I'm the Senior Public Policy Manager for the Alzheimer's Association here in New Hampshire. Just to address Representative Mazur's question, we usually meet about monthly, depending on, schedules and everything, but consistently, we are meeting pretty monthly for the Subcommittee on Alzheimer's and other related dementia. So we're incredibly grateful to Senator Prentice for her leadership and guidance on this piece of legislation. We know that there are over 26,500 people in the state of New Hampshire living with Alzheimer's or dementia, and a lot of those individuals will have interactions with our EMS personnel across the state. So we really feel that it's important to have communication and collaboration with our EMS personnel to develop understandings regarding behaviors and tools that can be utilized in order to help these situations be more positive and effective for everybody involved. Certainly, as I'm sure many of you are aware, someone who is living with Alzheimer's, they can become easily confused, they can wander. Oftentimes when they're in a stressful situation that can exacerbate behaviors that can present as combative or challenging. So we really are looking forward to and are very excited to work with our EMS community to help raise awareness of tools, raise awareness of strategies and the disease itself. And we think that this is a really good first step in terms of keeping those lines of communication open and constructive. So I'm happy to take any questions.
Thank you. Any questions for Ms. Horgan? If not, thank you.
Thank you so much.
That may be a record on a hearing. No one else has signed up to testify. Does anyone else wish to testify on SB 202? Seeing no one, I'm going to close the public hearing on SB 202. Our next hearing is scheduled for 2 p.m. On Senate Bill 251, so we will be in recess until then. Wow. Talk about speed dating. By the way, Lisa, I am glad that ivermectin was able to help you. I didn't want you to think. we are up to the last bill of the day, Senate Bill 251. And once again, I'm happy to introduce Senator Prentice, the prime sponsor. Welcome back.
Thank you, Chair McDonald and members of House, HHS, and Elderly Affairs. It's great to be back. That was just like a flash in time. I got some extra steps in by making it across the street, and I'm back. So, good afternoon. Thanks for seeing me again. I'm introducing Senate Bill 251, which is really reestablishing a commission that looks at the delivery of public health through our 13 regional public health networks. This is something that I started on at least 3 years ago, and the reason that we need to reestablish this is that we're not done with our work. So it's the situation where you look at this like once a summer I go and I get a plate of fried clams. Okay, I just love, fried whole belly clams. And the plate is really big and I'm fixated on them, but it's too much. I can't, eat it all in one sitting. That's what happened here. We only got down to, say, the last real 2 items of the commission. So let me give you the background and then we'll go back to my clams. My eyes are bigger than my stomach in that situation. Public health is delivered in this state through a series of regional networks, partnerships, from hospitals to fire departments to ambulance services to VNAs, all different types depending on where you are, working in the same communities of interest that exist in hospital service areas, regional EMS districts. There was a lot of thought, because I'm dating myself here, worked at Health and Human Service. Well, I worked at the Department of Safety when we did this project at Health and Human Services, and we formed these networks because what we recognized is that not every city or town can have a public health department. Now, there are health officers, and those are different than having a public health department. There are only 2 full-time public health departments in the state. One is in Nashua, and one is in Manchester. Even though they're their own freestanding entities, they too participate in the regional public health networks. These networks do everything from local assessments of health-related issues, which might be an uptick in diabetes. Managing, they do a lot of work based on their contract with Health and Human Services on substance misuse disorder. They also work in the area of emergency public health preparedness. So going back to, I don't know if any of you remember when there was a hepatitis outbreak related to a restaurant in Derry, and we needed to, again, dating myself, we needed to get out, not large doses of medication, but serve a large population that may have eaten at that restaurant within a certain period of time. This was well publicized. I'm not telling any secrets. We used these networks because they had plans to set up and dispense medication for large groups in terms of surge. They also were groups that have been pivotal in helping with flu vaccinations, as well as in the delivery of COVID vaccinations. They will do what they are needed to do to serve that particular public health need that comes up at that time. So in my effort to get a good handle on what it is they were doing, all 13 of them, where we had common areas, where we had differences, and to make recommendations for the future of these types of networks in this state. It took us almost 2 years to get to the report, which hopefully is in your packet or you've been able to get your hands on. The report that went out from our commission this year, it said, we've gotten this far, but what we still need to do is make our final recommendations. But before we can do that, the Department of Health and Human Services within the last 2 years engaged a contractor to do a similar analysis, not exactly the same. And Abby Rogers is here from DHHS, so she can speak to that. But they came up with structure and recommendations and what this could continue to look like or not. And we had that delivered to us. And this is with all due respect to parties involved, 3 months before we were statutorily due to sunset. So we really didn't have enough time to look and evaluate that report and make our final recommendations. So what I'm asking is that we are able to reestablish, and we have the agreement of everyone that was on this commission, and it's a big group because it's not just the 13 public health networks. Public Health Association was part of it. There were, Health and Human Services had a seat on it. There's a member of the House, there's a member of the Senate. We need to finish evaluating the study that was done by DHHS, look at our work in the last 2 years, and make a series of recommendations. What I can say to you with confidence is that this group is committed to doing this work. And what I can also say to you with confidence, knowing how we do our jobs, is that we can make recommendations. I can't promise that that a legislature will take them up and put them into place, but we have a duty to finish this work on behalf of, I really feel like, on behalf of the strong work of these public health networks in New Hampshire. So with that, I will conclude my testimony, and I am happy to take any questions you have. That's it.
When was this originally created?
Slow down. So this was, we had, I think, 2021, and then we extended out because we had some changes and couldn't get everyone together, and we started meeting in 2020, we started meeting in 2023, late 2023, all the way through 2024. There's dates of all of the meetings are in this report. Our inaugural meeting was on November 28th, 2023.
Okay, so it was at the end of last year that,
Yeah.
that the commission expired?
And it is. And,
Okay.
and I'll say, if I may, Chair, that this, having been involved in setting these up in the early days and working with these networks, it has been an important project to me, but I also had another commission for a senator who was leaving that I had to pick up at the same time. So I got a little delayed trying to juggle both of them. I don't want to devalue the work that's been done. We got behind, and that is largely falls on my shoulders.
Was it because of COVID that you didn't have a chance to meet that much in 21, 22?
No, we were largely out of COVID. We got the law passed then, but it was getting all of the people together.
Just conflicting schedules?
We needed to push it out a year. It was a much bigger plate than we had anticipated with the size of the commission. And honestly, I was a new senator. I thought that I could tackle it all, and figured out that it was going to take a lot more than just me to get all of the work done. It was a team effort, yes. So I'm here to finish that plate of clams, the other half that's been waiting, if you would so help us to get reestablished. Thank you.
Thank you. Representative Palazzo.
Thank you, Mr. Chair. Thank you for taking my question. Do we know how this coordination is done in other states, and would I be correct in assuming that in other states county government has public health offices that do it?
How do others, is your question? Thank you for the question. In terms of other states, we looked at other states, but we looked at other states, but Vermont, because it's so close, we were able to have Dr. Rudy Fedrizzini, who is embedded in a district office of Health and Human Services, to do similar work, come and talk about how they were managing a network-like structure. So it's not uncommon, but we did take the opportunity to pull a neighbor in. We also had the former Division of Public Health Director, Dr. Jose Montero, who has not only set these up, but is now working at the CDC and is familiar with the structures in other parts of the country, and the former director of this program in itself, and I'll probably get his title wrong, so I'll leave that to Abby. Some of you may remember Neil Twitchell. He came and met with us as well. I mean, we had an extensive list of people that we needed to talk to look at the landscape nationwide, not just in New England, but thank you for your question.
Thank you.
Anyone else? Representative Tejas.
Thank you, Mr. Chairman. Thank you for taking my question. You referenced a report. Was that a Shaw Ship report, or was it a report from this commission?
There's a report from this commission filed November 1st, 2024. And I'll actually leave a copy with your clerk. Oh, how are you? Good to see you. I just getting to see different faces around the table that that I haven't seen in a while. I will give this to the clerk to get copies made for all of you, so you can see our report, see the number of people who came and talked to us, the number of times we met, the size of the commission, and just some of the initial input.
Okay, thanks. But could I find that online if I look
Yeah,
in the
you
right place?
probably could. If you look at statutory commissions,
Okay.
you're going to find it in there. And look for under chapter one, it would be a Senate Bill 419 Senate Bill 127 from 2023, chapter 127-12I.
Thank you.
You're welcome.
Anyone else? Seeing no one else. Okay. Thank you, Senator.
Thank you, Chair McDonald and members.
Also signed up to speak is Abby Rogers from the Department of Health and Human Services.
Good afternoon, Mr. excuse me, Mr. Chair and members of the committee. My name is Abby Rogers. I'm the legislative liaison for the Division of Public Health Services, and I'm here today pinch hitting for my colleague Stephanie Locke, who is the Bureau Chief of Emergency Preparedness, Response, and Recovery. She is the person who served on this commission with Senator Prentice and worked closely with her on this work. The department wanted to provide some information on the importance of continuing this work of the commission. The commission worked with all of the public health networks, and as Senator Prentice as she described, had many stakeholders on the commission, many people who came and spoke and provided information to the commission, and there's still more work to be done. The current legislation being proposed has a very similar scope to the original scope of the commission that was established previously. Regional public health networks serve as liaisons and champions for their communities. They provide important health services in the communities. They are also a resource for information related to partner agencies as well as DHHS. As Senator Prentice mentioned, they work in the area of immunization, substance misuse prevention, and public health messaging to keep their communities healthy. They also work collaboratively on community health improvement plans in collaboration with local healthcare systems. And just here to say that the department is supportive of the continuation of the commission, and we are happy to serve as a continued resource to the commission in its ongoing work. So happy to take any questions if you have any.
Representative Polazov.
Thank you, Mr. Chair, and thank you for taking my question. Can you briefly describe what legal framework RPHNs operate on, what statutes create them, and if there was any consideration that this work could be done by county governments?
Sure, thank you for the question. Public health networks are not established in statute. They are still established locally within jurisdictions of counties, communities. The state is, I think when we started this program, again, Senator Prentice mentioned Jose Montero, who was a previous director of public health, was implemented 13 public health networks in New Hampshire, and those are not established by statute. Thank you.
Anyone else? Seeing no one else.
Thank
you. No one else has signed up to testify on Senate Bill 251. Does anyone else wish to testify? Seeing no one, I'm going to close the public hearing on Senate Bill 251. That is our last hearing scheduled for the day, so we will be adjourning. We will be meeting again on next Wednesday, starting at 9:30, to hear additional Senate bills. Until then, we stand adjourned. Thank you.